Hello, I'm Kerry from the Patient and Public Involvement team at the Royal College of Obstetricians and Gynaecologists. Thank you for joining us for our information webinar on menopause that we're holding in collaboration with the British Menopause Society. This session will give a broad overview of menopause, looking at symptoms, diagnosis, treatment and self-care and support. So just a few bits of housekeeping for those of you at home before we get started. We're expecting the session to run for about 45 minutes. We will be recording the session and it will be shown on social media in the near future. I know some of you have submitted questions ahead of the session, but you're also welcome to ask questions throughout the webinar as we go along by using the chat function in the bottom right hand of your corner there, which is a little purple button. The text for these chat questions won't appear on any recordings. We'll endeavour to answer as many questions as we can tonight, and we've got our fingers crossed that all technology is working, but if you are experiencing any problems, feel free to send through a private chat message and we'll see if we can offer any tips. So I'm joined by 4 guests. We have Marie and Bhavni, who are quite new to the world of menopause and have some questions they'd like answered by our healthcare professionals and also some experiences to share. And we also have 2 healthcare professionals, Hannah Short and Haitham Hamoda, who both have a wealth of experience and knowledge around all things menopause related. So Haitham and Hannah, can you tell us a little bit about what you do and about your roles? Hannah, I'll pass over to you first.
So I'm a GP and I'm also a menopause specialist. I do part-time work in GP surgeries on a locum basis, but I spend most of my time seeing women who are suffering with perimenopausal symptoms or menopausal symptoms and other symptoms related to hormonal health.
And Haitham?
I'm a consultant gynaecologist. I'm the lead for the menopause service at King's College Hospital and the chairman of the British Menopause Society. So we see patients with menopausal problems, premature ovarian insufficiency, and cases, again, with early symptoms or complex cases for additional advice.
Excellent, thank you. And Haitham, I know we have a range of people watching, many who are quite new to menopause. Are you able to give us a brief overview of what perimenopause and menopause are?
Yes. The menopause refers to the final menstrual period. So it refers to a decline in ovarian function. And as a result of this decline, the number of eggs within the ovaries decline, and the hormones produced from the ovaries also drop, and in particular the hormone estrogen that is responsible for many of the symptoms associated with the menopause. So as a result of this decline in function, the number of eggs declining, ovulation stops, and the menstrual periods stop. And as a result of that chronic low level of hormone levels, a woman can experience a number of menopause symptoms related to this. The perimenopause refers to the transition, the build-up to the menopause. So as the function of the ovaries decline and the hormone levels begin to drop, the menstrual periods can become slightly infrequent. So the pattern could change from a relatively regular pattern to a slightly more infrequent pattern. Menopause symptoms could begin. That's what's referred to as the early perimenopause. As that becomes more prominent, then and as the decline in ovarian function becomes more, the menstrual cycles could become more infrequent. The symptoms could get worse, and that's referred to as the late perimenopause. So on average, the average age of the early perimenopause is 47. The average age of the late perimenopause is 49. And as the final menstrual period happens, that happens on an average age at the age of 51. Of course, it's a range, so some women could go into the menopause earlier, some can go later. So the range could be anything between 45 and 55, but on average it's 51. Some women can go into the menopause early, so you've got about 5% can go into the menopause before the age of 45, about 1% can go into the menopause before the age of 40, and about 1 in 1,000 can go into the menopause before the age of 30. And of course, you enter into a situation in this younger ages, the issues of the health implications of it as well as the symptoms.
Okay, thank you, Haitham. And Hannah, Haitham's touched on some of those symptoms that women might experience. Can you give us a bit more detail around that and when a woman might seek some further help or support?
So, because there are hormone receptors throughout the body, you can have symptoms that are affecting every body system. So obviously the number one symptom that people think about are things like the hot flushes and night sweats. But mood-related symptoms are really common as well, especially in the perimenopause. So sometimes happening before you have the hot flushes and night sweats. And that's to do with the fluctuating levels and their effects on the brain. There's symptoms such as vaginal dryness or pain, itching, pain with intercourse as a result of the dryness, bladder pain, sometimes urinary tract infections or symptoms that are similar to that, joint aches, headaches, itching skin. There's a wide range of symptoms really. You can have constipation can be a problem because of the way the estrogen receptors affect the bowel. So the list is kind of just ongoing really, but they're kind of a lot of the common symptoms you see. Not every woman will experience hot flushes, but around 80% will. And around 75% of women will have 75 to 80% of women will have some symptoms, and a quarter of them will have severe symptoms. So the milder symptoms sometimes can respond to lifestyle changes, which we can probably talk about in a bit more detail at some point. But if you've made some lifestyle changes or you've tried something, say over the counter, and things really are kind of not improving, it's worth seeing your GP, making a list of your symptoms, and going in to having a discussion about what you would like to try, because there's a variety of things that can help.
And Bhavni, Marie, I've seen you shaking your head, sort of nodding in agreement with some of the things Hannah and Haitham have said. In terms of symptoms, do you want to share any of your experiences around some of those?
Yeah, definitely with the hot flushes. It can range at night time from feeling like you're in the middle of the Sahara Desert to the seventh circle of hell. You just feel it rising and it wakes you up, which then leads to sleeplessness. And severe night sweats as well. Not as much as some of my HF, so that's hot flush ladies, who have to change their clothes sometimes 2 or 3 times during the night. Other symptoms that I've had is becoming more emotional. Sometimes crying over a TV advert and not quite understanding why am I, feeling so emotional about these things. There are other things such as there are times where I don't want to be around anyone. I just need to be on my own, in a room, on my own, and nobody talk to me, which then sometimes leads me to having to force myself to go out because I don't always feel sociable anymore. And then there's also the thing of feeling that you're alone with this because, as you all know, people are beginning to talk about it more, but then when I went to a GP to talk about it, it was we'll give you antidepressants, and it's like, well, it's not depression. I think I'm starting the menopause, and then also that whole thing of just not feeling yourself anymore. Not feeling like your mind is your own anymore because you forget things or you start to wander off and things like that. And then just, as I said, just not feeling like me. And I would like to feel like me again, So those are some things for me.
Thanks for sharing, Marie. It's quite a few physical and mental symptoms to pick up on there. Is there anything you two would like to share around managing some of those symptoms, maybe starting with hot flushes?
First of all, I just wanted to refer what you've said. Unfortunately, these symptoms are fairly common, and the symptoms that people often associate with the menopause are the hot flushes and the night sweats. But the mood changes, the irritability, the changes in self-esteem, all of these symptoms are very common. Sometimes women wouldn't volunteer them, but they will answer them and mention them on direct questioning, and they are common, and HRT is very effective in dealing with them. But with regards to the hot flushes, of course, that's a typical symptom. It's the commonest symptom that patients present with. As Hannah referred to, so 75% or so of patients will experience it, and about 25% will have severe symptoms. And of course, it could be quite troublesome for many. Why did the hot flushes happen? Again, it's unclear. It's an effect of that chronic drop in estrogen levels, that chronic low estrogen effect on the temperature regulation centers in the brain. and that manifests in changes in the blood vessel dilatation and the nerve supply to the blood vessels that manifest in these hot flushes, which of course can be troublesome to many women. HRT is very effective in treating the symptoms. I think the one point to mention in that respect, you often see the mention of saying, I've tried preparation X or preparation Y or preparation Z and it didn't work and I moved on to another preparation. And the point to mention in respect to that is that you're often starting HRT at a certain entry point, and that might need modifying and fine-tuning to get you to the level that you need. So there's always a question of saying, you're taking an intervention, we're giving you estrogen, but how much estrogen are we giving you? How much are you absorbing from what we're giving you? And what level do you need to control your symptoms? But with these adjustments, with this fine-tuning, often most patients, we would get them back to a very good place, good control of these symptoms.
Okay. And Hannah, have you got anything to add in terms of managing that symptom and different treatment options?
In terms of hot flushes, yes, particularly? Well, I guess obviously for a lot of women, HRT is going to be something that is going to be beneficial, but not everybody will need that. Some women won't want to take it or won't, or choose not to take it or aren't able to take it if they say they have a hormone-dependent breast cancer, for example. So some of the lifestyle things that can kind of help is watching out for triggers. So some women particularly respond to caffeine or alcohol or excess sugar and things like that they can trigger hot flushes. Stress, but again that's a bit of a vicious cycle because the hot flushes can make you stressed. So if stress is a part of the picture, then things like cognitive behavioural therapy, CBT, can be quite helpful for hot flushes then. But that can be quite difficult to access in many ways. Having a fan, having access to cold water, wearing kind of natural fibres, things like cotton and things like that can be helpful. So there's things like that can kind of make things a bit more comfortable. If you're not able to take HRT, then actually the antidepressants can actually be given to, so women who are having breast cancer treatment may be given that, can sometimes help with the hot flushes. There's some evidence that things like acupuncture can help as well, and sometimes people can be referred for that on the NHS, especially if they're cancer patients. There's some evidence for phytoestrogens, so things like soya and red clover, that can also be beneficial. So.
And Marie mentioned that kind of feeling of being alone in everything, and the kind of emotional well-being side of things. Is there anything that you two might want to add to that in terms of managing that as part of your life?
I mean, again, in addition of, as Hannah mentioned, lifestyle modifications generally are effective, including exercise as well, which many patients find helpful in addition to the diet modifications. But again, it's an effect of estrogen deficiency. It's a direct effect resulting from estrogen deficiency, and replacing estrogen is very effective in treating that. Also, testosterone replacement. So while testosterone is often added to improve libido and sexual drive, it's also been shown in studies to be beneficial from a mood point of view and energy point of view. So we would often do it in a stepwise fashion. So you would say if you're experiencing menopausal symptoms, we would start with giving estrogen and progesterone, which is given to protect the lining of the womb from the effect of estrogen. If someone has had a hysterectomy, HRT in that case will be estrogen only. So that'll be the initial step. And then you would assess how you would respond to these symptoms. And then the next step would be to consider testosterone if there are ongoing issues to do with mood, energy, or libido.
I think alcohol, again, is one of the main things that can really influence mood. And I see a lot of women who probably are drinking more than they used to because they're feeling so awful, or maybe having a glass of wine to help them sleep at night. But actually it just disturbs the sleep, it worsens the sleep thing, it worsens mood, can make your hot flushes worse, has a negative effect on energy. So all of that can contribute as well. So, but I agree. And the NICE guidelines, don't they recommend HRT as first-line treatment for mood symptoms if lifestyle modifications haven't helped. But if you're having HRT and you're not looking at things like alcohol and whether you have a lot of processed foods and things, that there's the things you can do to tweak it that can make things better as well. So I always recommend a diet full of fruits and vegetables and whole grains, beans. So that's largely anti-inflammatory diet that can help in addition to HRT or by itself as well.
And you touched on sleep problems there. I know we had a question submitted ahead of time asking for the latest advice and guidance around severe sleep problems. Is there anything that you could share around that?
Sleep could be, again, multifactorial, the effect of the menopause on sleep. So you could have a direct effect of estrogen deficiency on the brain that can affect sleep. So sleep disturbances could be a direct effect of that. But also as a result of the hot flushes and the night sweats. So if you wake up with hot flushes and night sweats, your sleep is going to be disturbed. If you're going to be tired during the day, your sleep is likely to be disturbed. So it could be multifactorial. So from that point of view, again, estrogen is very effective in treating it. And of course, lifestyle modifications, be it caffeine intake, alcohol intake, all of this could have an effect. Going back to the earlier point as well, when you're referring to the mood changes and where would HRT fit into it, it's relevant to say that many of these symptoms can be multifactorial. And again, it's important to look at the pattern to assess how these symptoms started. So if someone has started experiencing changes in mood and the other symptoms in, say, their mid-40s or late 40s or in their early 50s, that's very likely to be hormone related, as opposed to someone who might say to you, I've had these symptoms throughout my, for many years, and it predated that. But if it starts around the time of the menopause or in the build-up to it, it's very likely to be hormone related. It's very likely to benefit from hormone replacement. And you would say in that situation, HRT would be your first line rather than antidepressants. Mm-hmm. And HRT is more effective in that context.
And Bhavni, is there anything you'd like to share with us with regards to symptoms?
Yeah, so I'm a little bit different in that I'm perimenopausal, and actually by your definition maybe early stage. I'm a reasonably young lady, and so for me my symptoms perhaps aren't escalated to the same levels, but one of the things that I've noticed a lot, and I call it as just seeing red. I'll have moments where, my goodness, the anger flares up in me and I feel like my head might explode. I've put on weight, and I've also noticed my hair thinning, so they're kind of reasonably early stage symptoms. The other thing I was going to say was probably increased anxiety as well, but for being a young 42, as you said, these may be hormone related, but going to the doctor, I don't think my GP would have necessarily automatically related them to being hormone related or perimenopausal. I was lucky enough to have blood tests to kind of identify that. So I guess they're my main symptoms. And for me, I also suffer with endometriosis and adenomyosis. So I guess one of my biggest questions was, how do I manage this when estrogens possibly are not going to be the best form of treatment?
So, it's possible to have HRT with diagnosis of endometriosis. You need to be monitored. So, as Haitham said, if you're given estrogen, you need progesterone anyway to protect the lining of your womb from the action of estrogen. But progesterone also helps reduce the risk of further development of endometriosis. So it can be quite a good combination, say having a Mirena coil, which that can help, that provides the progesterone, can sometimes help with reducing blood loss as well if you have heavy periods. And so that can help mitigate the effects of estrogen in terms of triggering any endometriosis pain. And I don't know, I've found sometimes with some of the endometriosis patients I've seen, having like a stable level of estrogen actually can be helpful in terms of the endometriosis. So in perimenopause, you've got the fluctuating levels. If you actually give hormone replacement therapy, perhaps starting at a low level just to see how you respond, having that as a stable background can be more beneficial. But I don't know.
I totally agree. I mean, I think if you look at it from a point of view of saying, how do most patients with endometriosis react or respond to taking HRT, you would say the risk of aggravating your endometriosis is very little. If you have got severe endometriosis and you find there is aggravation with taking HRT, taking progesterone in a continuous way, like something like the Mirena coil, and giving estrogen with it would be helpful. Giving progesterone in a continuous way affects how estrogen can react, can affect the tissues. And if you look at pregnancy, for example, women who are pregnant have got very high levels of estrogen, but they've also got very high levels of progesterone released continuously. So that affects how estrogen could affect the tissues. And that's why you find endometriosis generally in most patients improves in pregnancy. So that's one way of looking at it, that if you have got endometriosis and it's reacting to you taking HRT, you could take a continuous progesterone intake like the Marie coil. But you've also highlighted another point, which is your age. So at 42, one of the issues that would be a concern is not just the symptoms that you're having, is the effect that estrogen would have on your general health. So estrogen is a very important hormone for female health. And if you look at it from your teenage years, the development of secondary sexual characteristics is related to estrogen. As you go on into your teens, your 20s, your 30s and 40s, estrogen is very important for bone health, heart health, cardiovascular health. That's why if you look at it, women have a lower risk of heart disease compared to men, and that's the protective effect of estrogen. It's got cognitive benefits. So there are studies that suggest that potentially the risk of dementia can be increased with early menopause if estrogen replacement is not given. And we do know by giving estrogen, we could protect against the risk of osteoporosis, we could protect against the risk of heart disease, protect against cognitive effects as dementia. So in addition to the symptoms, there are these additional benefits that need to be discussed as well.
So the response is to go and see a specialist.
And actually, that's a good point, Bhavni. So, Hannah, you might be the first point of call for a lot of women who have questions around symptoms. Haitham, when would a woman come to see you with regards to menopause?
So I would say if you've got problems, the first port of call would be your GP. And many GPs will have an interest in this area, will have some experience to guide you through that initial step.
Or lots of experience and knowledge.
Yes, and it'll be a question of saying that'll be the first port of entry. Now, if there are issues in managing your hormone replacement or difficulty in identifying the cause, because if your periods space out and stop and you've got hot flushes and night sweats, you could say that's an obvious diagnosis. In many situations, it might not be very clear. And of course, it can cause a lot of effect. So again, if it's unclear, getting referred to a specialist clinic to try and say, first of all, let's establish what is causing these symptoms would be an option. We would see patients who would either have taken HRT but have got problems finding the right preparation. So they've taken it and they still have got symptoms, or they've got issues with irregular bleeding. So which again, what both groups would need is a modification of their intake. So if you've got ongoing symptoms, you're probably not getting enough of your estrogen or testosterone replacement. If you've got ongoing issues with bleeding, the progesterone might need to be modified. So that's one group we would see. Another group we would see are patients with high-risk medical background. So let's say people who have got, maybe they're concerned about a family history of breast cancer, maybe they're concerned because there are issues with weight, family history of blood clots, other medical risk factors that I might say, is it safe for me to take HRT, or if I take it, how should I take it and what preparation could I take? And these are groups that we would generally see.
And the British Menopause Society has some information about finding a specialist.
The British Menopause Society and the patients arm of the Society of Women's Health Concern have got plenty of information that's really available to the public, is available to practitioners and to GPs as well. So that's a resource that could be accessed to look at this information. Menopause Matters is another website that has got plenty of patient information leaflets that could be assessed. And for early menopause, the Daisy Network is another charity that provides support and information to patients in addition to the British Menopause Society.
And we've touched on surgical menopause, but haven't given much detail. Hannah, can you tell us a bit about that and how women might find that a different experience?
Yeah. So surgical menopause happens when the ovaries are removed, and that may be together with a hysterectomy, so the womb being removed as well, but sometimes it's just the ovaries that are removed, and then that results in an instant menopause. So, I mean, that can happen premenopausally, or it can happen when a woman's already gone through a natural menopause, and it depends on the reason for having her ovaries removed. So there's more and more women who are having their ovaries removed for, say, they're positive for the BRCA1 gene, so an increased risk of breast cancer or ovarian cancer. They'll often have their ovaries removed but still keep their womb. Then there will be women who've had their ovaries removed as a result of cancer or endometriosis. sometimes for severe premenstrual syndrome known as PMDD, premenstrual dysphoric disorder. So there's all of these things, and it can happen at any age really, I suppose, from late teenage years right through to post-menopause, depending on the cause. The difference between surgical and natural menopause is that it's instant, and especially if you're young, when you have those ovaries removed, then the results can be quite severe and they will be quite sudden. So perimenopause can last for up to kind of 10 years as ovarian function starts to kind of wind down in natural menopause, but in surgical menopause you could have a normal, inverted commas, level of hormones, and then overnight it kind of bottoms out. So the symptoms can be more extreme than natural menopause, and that's I think sometimes some practitioners don't seem to differentiate between a natural and a surgical menopause, but they are very different things. The symptoms can be similar, but they are different, and they need to be kind of managed in a slightly different way. Sometimes you might be more likely to have a higher level of HRT if that's a route that you go down. Or in some patients, HRT may not be appropriate, but you need to recognise the symptoms can be quite severe and we need to treat them. So.
And I think Bhavni and Marie might have some questions that we've had pre-submitted. Is there anything you'd like to share at the moment?
Yes, there was one. There's a few. There's a lot of talk with regards to menopausal women and their lack or loss of libido. And somebody had asked that when they've tried to talk to their doctor about it, they've not had a positive response. So they want you to know, what help is there out there for women who have lost their libido due to the menopause, or do you have any tips of what they could actually say to their doctors?
So if you look at it and say, why would that be the case, to start with answering the question and saying that libido can drop after the menopause, and it could be related to two aspects. One aspect is the drop of the hormones and its effect on the centers in the brain, so the sexual arousal centers in the brain, but there also could be an effect to the drop on estrogen, on the effect on the vaginal tissue and the thinning of it. So that could cause, in time, thinning of the tissues, discomfort, which could affect libido. But of course the biggest part of it is the drive related to the effect of the drop of the hormones on the brain. It's a common symptom, and again, many patients might not feel comfortable bringing it up, and that's another aspect. So it's an important area to address with patients, because help is available. Hormone replacement is very effective in improving it. So if you look at it and say, from a point of view of addressing it, HRT with estrogen is a first line in treating that. And then testosterone could be added as an addition to help with that. And from the vaginal dryness point of view, vaginal estrogen can be given in addition to the systemic HRT. And patients often wonder, if I'm taking systemic HRT, why do I need to take vaginal estrogen? Systemic HRT or systemic estrogen will help with vaginal dryness, but would not fully resolve it. And in fact, you find many patients will find additional benefit from taking vaginal estrogen in addition to systemic estrogen. So we would often say, with the systemic HRT, doing it in a stepwise fashion. So you could take estrogen systemically, be it patch, gel, or tablet. Then you see what benefits you get. And then as a next step, you could consider adding testosterone as the next step. And both of these are very effective. And of course, this will be combined with vaginal estrogen. It could be combined with vaginal estrogen.
And Hannah, is this something you see many women about in your clinic as a symptom?
Yeah, I think it's really common, and it can be quite distressing for women. And yeah, as Haitham said, often it does respond quite well to HRT. And sometimes that's because the hormone deficiency itself is partly responsible, and sometimes it's the resolution of the other symptoms. So if you're not sleeping, or you're feeling anxious, or you're feeling moody, or you have severe vaginal symptoms, you're not going to feel like having sex. And then it becomes a bit of a vicious cycle, because you just don't want to go there, and even unconsciously I think that can cause issues. So yeah, it's certainly something I see and talk about, and recommend what Haitham's saying. But I think it can be difficult, and you're saying just bringing it up and talking about it. So I often refer patients to a site that we're going to kind of put, I think, at the bottom, which is very useful, and it's got lots of information about women's sexual health and how to talk about it with your partner and what to do after menopause. Things like using vaginal lubricants that can help with sex as well, which then if you do have sex and it's not as uncomfortable, in addition to maybe using vaginal oestrogen, using some lubrication can be beneficial too. And then that kind of feed forward, then you're more likely to enjoy it or be thinking about it again because it didn't hurt. And so it's kind of has that reverse response. You're kind of encouraging kind of sexual activity if it's not so uncomfortable anymore. But it's just making sure women are using the right lubricants. So something like Yes Organic that doesn't have parabens or anything nasty in it, that can be good. So avoiding things like KY jelly that's irritating to the tissues that a lot of women use. I do talk about use of things like clitoral vibrators sometimes if women are too scared to have penetrative sex and things, because that can improve blood flow. But we put links at the end of this, because go to the website, it's on jodevine.com, and the articles there, because that's often where I refer women to, and it's got a lot of good information about speaking to partners and stuff. And but it's like all of these things, they're multifactorial, so the hormone deficiency, the results of that, including the other symptoms, and then almost getting out of the habit as well. But yeah, if vaginal symptoms are a real problem, that's the first thing to get corrected, because nobody's going to feel like having sex if they're in pain. So
one other thing I was going to mention is one of the issues in this area is the issue with availability of testosterone preparations. So testosterone has been looked at in studies for many years. We know it works very well in this context. However, the issue is at present is the availability of products in the UK market. So we haven't got a licensed testosterone preparation. So we're using preparations that are manufactured for use in men outside their manufacturer's license. Now, that could sometimes make patients think, concerned in that respect. And if you look at it, we do use many medicines out with their manufacturer's license, so there is a pathway of doing it, and if a product is not available, it can be used in that context. But also we are giving it in female physiological doses. So if you're taking a testosterone sachet, let's say a man may take, let's say, a whole sachet a day, you'll be taking about a tenth of a sachet a day, so you're taking 5 milligrams a day, which is a female physiological replacement level, which will give effective control of the symptoms and unlikely to give side effects in that respect.
And obviously loss of libido is something that you might find difficult to raise as an issue with your healthcare professional, and also issues around bladder symptoms. Is that something that you see women about as well?
Yeah, definitely see the bladder symptoms are quite common, or the recurrent UTIs, or feeling like you're going to have a UTI. And then I see a lot of women who have urine samples sent off, but then there's no bacteria growing there. And especially see this in women who are quite a few years down the line post-menopause, so in their 60s, 70s, 80s, and often that's a result of oestrogen deficiency, and that's when vaginal oestrogen can be helpful. And you don't actually necessarily need to take the systemic with it, but often they can be taken together. But especially further down the line, it may be just needing that vaginal oestrogen. So yeah, it's something that's very, very common. There is, I think, related to menopause matters, there's a site called Bladder Matters, and it talks about things like that. I mean, it is difficult to bring these things up for some women, but it's important women know they're not on their own. These are very common. I think if people find it really hard to talk about, maybe write it down. And then that can open up the conversation. I mean, there probably are guides and stuff online to how to approach this. I can't think of one to hand up other than the website I've mentioned, but I think writing something down, so patients sometimes do that to me, they'll bring something in and say this is really problematic. So.
And Bhavni, have you got any questions that have been pre-submitted for us?
Well, actually, it's a slightly personal question, but we've talked a lot about using estrogens or HRT. What changes can individuals make in their lifestyle that might help kind of support them through the process or aid anything else?
So yeah, I always talk about this in quite a lot of detail when I'm able to, when time allows. But so nutrition is one thing, and I generally advise women to focus their meals around plant-based foods. So having, it doesn't necessarily need to be exclusively vegetarian or vegan, but most of the diet should be whole plant-based foods, so beans, legumes, whole grains, vegetables and fruits. Try and minimise processed foods. Often recommending that people switch cow's milk for soya, because as long as it's fortified and has the calcium, because that's more beneficial for heart health and can sometimes have an impact on the symptoms. It's not going to help a lot with severe symptoms, but it's certainly going to be beneficial if there's no soya allergy or anything like that. So yeah, and like I've said before, minimising alcohol, sugar, trans fats. Exercise, as Haytham's mentioned, is very important, but I know that some women really struggle if fatigue or joint pain and things like that. So starting with something like maybe gentle yoga can be helpful, or walking or swimming. You do need to do weight-bearing exercise actually to help with the bone strength as well, and bone density going forward. So that's when like walking, running, tennis, that kind of stuff can be helpful. But if you're just starting out and you feel really kind of low, just start with something gentle and build up. And if your symptoms are severe, certainly go and see your doctor about HRT, because that can often make women feel more able and motivated to exercise. I recommend sometimes like meditation apps, things. There's one called Clarity, which is developed specifically for menopausal women, and it's got little sections on anxiety, hot flushes and sleep. That can be helpful. There's a good book I recommend by Rangan Chatterjee called The Stress Solution, which has got lots of little tips. So it's not about menopause, but just generally can help with anything that has a stress-related component. And I think any situation you're in, and I conclude menopause in this, that makes you feel stressed on a daily level will benefit from some of those changes. So they're the main things that I recommend, but I don't know if...
Totally agree. I think it's a multifactorial approach, is saying looking at an individual holistically. And of course, when you talk about symptoms and you talk about managing them in addition to HRT, you're talking about diet, exercise, same thing with cardiovascular. If you look at it and we're talking that HRT could reduce your risk of cardiovascular disease, but also looking at what else could you do to reduce it. So between exercise, weight, cutting down smoking, alcohol intake, and diet modification, that could all have a beneficial effect. Looking at blood lipids, blood sugar, again, as happens with, let's say, midlife health checks, in assessing to say, is that an area that could be addressed or needs to be addressed? You talk about the bone as well. So HRT is very effective in protecting against osteoporosis, protecting bones, but also if you look at it from weight-bearing exercise, looking at whether you need vitamin D supplements, and that could all help as well in improving bone density and bone health.
Just there's one other thing that I mentioned, guys, is in terms of sleep, but it can also help, is trying to keep a regular nighttime pattern, which I think a lot of people who've had problems with sleeping will kind of be aware of. It's hard if you're kind of waking because of palpitations or hot flushes and things like that. But trying to get into that routine and trying to get some early morning light as well, because it affects the pineal gland, which can have an effect on things as well. So just trying to expose yourself to morning light as well. It sounds like a strange thing to do, but it can have a positive impact as just part of a healthy lifestyle. But then that's probably just genuine kind of like general sleep advice, not necessary to menopause, but that can help.
And do we have any questions that have come through, Matt?
Yeah, we do. So there's a question about the current shortages in HRT supplies. People wondering if there's any news on that.
So this, of course, has been a problem that we have faced, that has been troubling many patients and have been having difficulty obtaining their HRT supplies, and this has been ongoing for a few months now. So the British Menopause Society, the Royal College of Obstetricians and Gynaecologists, the Faculty of Sexual and Reproductive Health, the Royal College of General Practitioners have all been in discussion with the Department of Health to try and understand it first of all, to see what is going on, and also to try and find measures to resolve it. So really the information that we've been given is that this is an issue to do with problems with shortages in manufacturing, problems in manufacturing and in supplies. So we haven't been given great detail to what the exact cause for these are. So we're taking almost two lines of saying the immediate line is to help women say, right, you're on this preparation, you can't get hold of it, what can you do? And that's really kind of the immediate problem in saying what alternatives are available. So the British Menopause Society has been issuing regular updates with on update and availability of HRT preparation. So it will tell you what is available, what is short in supply, and that's available to the public, it's available to general practitioners. So you could look at it and say, I'm taking this preparation, what is an equivalent? And most general practitioners and pharmacists would be able to look at that to guide them. And what we would say is that while there are shortages affecting certain patch preparations, there are alternatives. So it's perfectly reasonable for you to stay on the preparation, on the way HRT is given to you. So if you are on a patch, there are patch alternatives. If you're taking estrogen through your skin, you could continue with either patch or gel, which will give you the same benefits of your original preparation. The same thing with progesterone. So there are alternatives that are available. So that is the main message to give to patients, to say that you've got that aspect of it. Of course, from our point of view, the next step is to try and understand it and really resolve it and prevent it happening again in the future.
Thank you. Any other questions?
Yeah, here's another one. So the question is, how can women get access to a specialist if their GP feels they are able to treat and support the woman with her menopause?
Okay. There's the British Menopause Society has got a list of accredited specialists. So you can go to the website and you can find a BMS Menopause Specialist, and it will come up if you just put your postcode in. So there'll be NHS and private specialists there. So your GP can refer you, or you could choose to see somebody that way. But your GP should be able to refer you to somebody on the NHS. I mean, unfortunately there aren't as many as we would like there to be. But I mean, you're entitled to kind of be referred to the closest one.
And would the NICE guidelines be a useful resource?
They can be, yeah, I think they're always useful. And then there's the Primary Care Women's Health Forum, which I kind of mentioned as well before, it's got some useful resources for GP, as does the RCGP has got some information. So patients can look there before they go and see their GP if they wanted to. But if the GP is struggling, then certainly referral by the BMS specialist is recommended.
I would also add that on the British Menopause Society website there are a number of consensus statements, tools for clinicians, and again lots of patient information leaflets. So that will be a useful resource for people to look at, because it will explain what the symptoms are, what the options for treatment are, and management of menopause in certain complex cases as well. So that's all available. It's in the public domain to look at.
And we'll make sure to include links to all of those resources at the end of the session. Any other questions?
There's comments here around the importance of menopausal support in the workplace. I don't know if anyone has any comments on that.
I would say this is a very welcome move that has happened of late in looking at the aspect of the menopause and how women in the workforce can be supported. If you think about it, every woman will go through the menopause. If you look at the proportion of women between the age of 50 and 64, it's estimated about 3.5 million women in the UK are in that age category. And of course, work can be stressful as it is. Imagine if you're getting all these hot flushes and you're not sleeping well and you're tired, that could be an additional issue. And many women might find it difficult, and it would affect their day-to-day work life as well as their personal and social lives. So this whole aspect has been looked at. There have been a number of bodies that have issued guidelines on it. The British Menopause Society has also issued a statement on it, and it's got quite detailed suggestions on what could be done in that respect. And really the main aspect of, if you say what can be done and how could it be done, it's all about really raising awareness of the employees and the employers. So you would want you as an employee to know, what is the problem that you're experiencing and what are your lines of help that you could access. And from an employer to know that you are having the difficulties or the symptoms that you're having because of the menopause. What does the menopause mean, and what can be done about it? Because for most, help is available, and help works, as we've talked about earlier on, fairly quickly. So if you're having these symptoms, a referral and a discussion, you could probably find, if we're starting HRT within weeks or months, things are fairly back to a very good place, and of course that would be beneficial all round for patient and employers. So it's finding these measures at that level to have these discussions and provide help to patients is the way with that.
I think we're coming to the end of the session now. I was wondering if you all want to share some top takeaway tips for people who are watching at home.
I think the main thing is just remembering that every woman is individual, and what works for one person is not going to work for somebody else. Obviously take on board like the lifestyle stuff, but if you're really struggling, please go and see your doctor. And if you're not getting much joy with the initial doctor, if you don't feel listened to, please see somebody else. And if you're really struggling, you can ask for a referral to a specialist. So.
Bhavni, Marie, anything you'd like to share?
I think it would be really to talk about it. Talk to your friends, talk to your doctor. There's been some really good links that have been mentioned will be on at the end of this session. If you don't talk about it, you can't get the help.
Very true.
I'd really echo that and just say that actually it's really important to know what these symptoms are or the signs of the symptoms, because the sooner you recognise what is happening, the sooner you'll be able to get some help with it as well. And just to say that the college also has their Menopause Hub, which is a good resource to really capture all of this information as well.
And Haitham?
Again, I would say the same thing about individualisation is important, but also to look at the intervention of HRT in the wider context. So symptoms, of course, are the main indication, and HRT is very effective for them. But often this is put and with the worry about breast cancer. And what gets forgotten in this equation is the other benefits of HRT, the cardiovascular benefits, the bone benefits. And if you look at it really in the context of benefits risks, for most women under the age of 60, HRT has got more benefits. The benefits risk ratio is low, it's more favourable. And that'll be a point to stress, that the risk of breast cancer is there, it's small, but it's there, but there are other benefits, symptom benefits, bone benefits, cardiovascular benefits that could be beneficial and help women.
Lovely. Well, thank you all very much for joining us, and thank you to all of those of you who are watching at home. Goodbye.